Thank you all for hanging out for some little more data this afternoon on the last day. And I do need to clarify one quick little thing about the post-hole digging. I grew up on a farm in Ohio, and who here's from Columbus? Any of the Columbus folks here? Woo! So I grew up outside Columbus, and I'm going to be there in a few weeks, and Carol's at the same conference, so I'm actually going to take her to my parents' pumpkin farm. It's going to be October 22nd. My parents are thrilled. We have a special wagon ride set up. Yeah. We have a petting zoo and a 4-acre corn maze. It's the works. So you can imagine there's a lot of holes that had to be dug. So we heard Jack Shonkoff yesterday talk a lot about health and certainly its relationship to children. And I'm, as Kathleen said, I'm a pediatrician as well. And the health connection we're going to dig into a little bit more deeply here today. But really in many ways, how many of you were here last year? Oh good, so quite a few. So you saw me. And how many have been to one of the Federal Reserve Bank Healthy Communities meetings? Anybody? Just a few, okay. Oh yeah, of course, the Chicago Feds in the back, they hosted one, so that counts. So this is going to, the goal was to, we'll do a little background because it's always good to catch people up, but the focus today is really to focus on what's happened in the past year. What's new, what's going on, why do we think there's hope going forward? But then Ian's going to step in and talk a little bit about why the scope of the problem is still overwhelming the green shoots that we are seeing and why we're going to have to really lead to systems change if we're going to attempt to solve this problem. So we're going to define the problem first. So I know this is hard to read. These are always bad slides to have. But in general, the problem is our health is a lot worse than it should be. Okay, we know that. This on the left side there, these are nations lined up left and right, and the important part of these arrows. And what we see is from 1980 to 2009, so 30 years, although our life expectancy did go up, it's about 74 here to about 79 here, we dropped further and further back. So other countries are lapping us. This is a big problem because we spend twice per capita on medical care than any other country in the world. Now think about that. If we cut our healthcare expenditures in half, we would still spend more than any other nation per capita in the world. That would be $1.5 trillion per year that we could spend on other things. Just ponder the implications of that. And this is why, in my opinion, community development is the way to spend some of that money differently. The reason we have this trouble is because we spend all of our money in the wrong place. We're spending it on healthcare. This is the, many of you saw this last year, this is what they call the fundamental causes of premature death, really of poor health that leads to death. Healthcare really only accounts for about 10%. The bulk of the issue really is social circumstances, environmental exposures, and behavioral patterns, all of which are very heavily influenced by the neighborhoods we live in. What is health? Health is really education. So what we have here is a graph. This is life expectancy, years of life left at age 25, based on your educational level. You got men on the left, women on the right. What you see here is 47 years compared to 56, 10-year difference in life expectancy, depending on whether you went to high school or went to college. So people who get a college degree are, in general, likely to live 10 full years longer than someone who just has a high school degree. Now, Jack Shonkoff pointed out really rightly yesterday, and this is important to remember, these are averages. So this is not written in stone. It's not like everybody knocks off who went to high school 10 years prior, right? This is on average. So there are going to be lots of people who went to high school that live longer than people who went to college. But in general, your risks are much higher, okay? This works out to about 72 versus 82 years. Women have the same gradient. They live longer, but it's pretty similar, actually. Health also equals income. Okay, this is the gradient by income. So what we have here is, these are children. So all these issues affect children and adults. So on the left side, this is the percent of children that have poor health. The darker is the poorer. So the very darkest bar is less than 100% of the federal poverty level. Okay? So 1 in 3 children who are the poorest have poor health. Compared to the wealthiest children, 1 in 14. Okay? What's amazing, and this is obesity on the right, if you put about any disease you can think of, it would be this similar gradient. If you put the same pictures up for adults and adult diseases, same exact gradient. What is incredible, look at that marching down step, right? This is not an us versus them issue. I think for a long time, certainly growing up in rural Ohio, there was a feeling of there are those poor people. They do bad things, they die early, bad things happen to them, but we're okay. Every dollar you make lengthens your life. Every year of education you have lengthens your life. This is really profound because everybody's affected. This means the whole middle class falls into this gradient. Why are the wealthiest living longer than we are? Why are the more educated living longer than we are? This is another important image. This is the same slide, but this is now adult poor health, but broken out by race and ethnicity. This is not a racial issue. What you see here is black, Hispanic, and white non-Hispanic on the right. This is income, same thing, 100%, 200%, 300%, and more than 400% of the federal poverty level. Look how similar those gradients are. Now you can see it's actually relatively subtle. It's amazing how subtle it is. It's a little bit, you're worse off if you're African American or worse off if you're Latino, but not that much. So income really, it's a little bit like earlier today, we were talking about place over race. It's also income over race. The trouble is income and place are so tightly bound. So the concentration of poverty falls really heavily amongst Latinos and African Americans, okay? The gradient still applies, but you see here, this is the percent of people in poverty. This is in 2011. Almost over a quarter of adults, African Americans and Latinos, were living in poverty. Over a third of children of African American and Latino descent were living in poverty. Now this graph also has a caveat because these numbers are before the social system catches these kids. So it's not quite as bad as this. But it's important to remember our social system, as we know, doesn't catch all the kids. So there's still a lot of kids living in poverty. This would be a lot lower, but it's also valuable to remember that in a place like Sweden, there are no poor children. None. They divert resources. Our social system that provides some food stamps and stuff helps those families. Theirs is so rich that those families end up with a middle class income if you have children. They've just made the conscious decision that that's where they're investing their money. So place matters, income matters, education matters, and this plays out. This is Raj Chetty, who's an economist at Harvard, and what he showed, this is social mobility. People get trapped in neighborhoods. So these are regions, the darker areas here, the sort of reddish areas, are where the lowest social mobility are. This is the likelihood of moving from the lowest fifth of the income to the highest fifth during your lifetime. The worst place in the United States is Atlanta, Georgia. I know, woo. 4%. 4%, 4 out of 100 children will actually make that switch. What's amazing to me actually is San Francisco and Salt Lake City have the best in the country. It's 11%. 10% of kids in the lowest fifth will actually make it to the highest fifth, which is kind of the American dream, right? There's a joke now that if you want the American dream, you should move to Denmark. Because we have very little mobility. It's really important to remember that. We have created a society where there's very little mobility. We talk about it, but it's actually not present, and it really comes back to the neighborhoods. So that was regional, and many of you saw this map last year. This is New Orleans. So we've talked about income and education are related to health, and we talked about income and education are related to concentrated poverty. What we see here is bringing those together. Health is related to place. So those of you who have seen it, here's the Lakeview neighborhood. This is life expectancy by exit ramp off the freeways in New Orleans. They literally go around the exit ramps. 80 years, which is about the national average in the Lakeview neighborhood. 5 miles away, this is the Iberville area right near the French Quarter. 55 years. That's a 25-year life expectancy difference in 5 miles. Anyone know what the life expectancy, what country has a life expectancy of 55 years? Zimbabwe. Zimbabwe, one of the worst countries in sub-Saharan Africa. So this is why we know, this is the terminology, your zip code is more important than your genetic code. And it's really taking a long time. This is where all of you are far in advance of the medical system right now. This came up, I think actually Jack Shonkoff mentioned the idea, if we spent as much money invested in changing the place, the zip code, as we do in defining the genetic code, we'd be in a much better position. And we just aren't quite there yet. People get sick because of their environments, and this we know. So it's all these things here, and this is around 5-6 years ago when I really was discovering what community development was. Here I was a physician. I had worked in a low-income community for many years after residency. I had never heard of community development. I had no idea it existed. None of my colleagues in public health knew it existed. There's a little bit of overlap with like the urban planning and the city health departments, but not as much as you'd expect. All these things we say are what's important, and these are all the very things that many of you are working on. So health happens in neighborhoods, right? That we know. And one thing we'd like to talk about, actually, it's David Erickson at the San Francisco Fed likes to say that community development is in the zip code improvement business. And he also says that your body is the sum record of the advantages, the opportunities, and the disadvantages that you face through your life. And those things really sink in. So that's just sort of the quick background, but let's talk about progress. I want to talk a little bit about what's going on new. So we talked about, this is the What Works book. So since it came out, it has, I forget how many of you guys, like third, fourth printing now?
Yeah, 20,000, I think.
20,000 of these. This is a book coming out of the Federal Reserve, and that's actual books. Those are actual books that have been printed and mailed. So by the way, any of you can go to this website and ask for a hard copy, and they will mail it to you for free. You can also download the whole book for free, or any of the chapters. And as we heard, Shirley and David have a chapter. Angela Blanchard has a chapter. And in fact, when Angela told the story about meeting the president, Nancy Andrews, who through Low Income Investment Fund, who helped write this, was at the same meeting and handed the president a copy of the book at that meeting. And this is Risa Levisos Amore's quote from the book, actually, really, again, saying that public health and community development aren't even just related. They really are effectively the same thing, and I think we'll eventually see it that way. Oh, and what I was going to add there is that there have been a number, I forget how many of these What Works gatherings around the country. So it has been an opportunity for groups to get together and talk about, basically talk about purpose-built, as a matter of fact. So state of the art, this was really the conclusion, is what is the state of the art? Comprehensive, place-based, evidence-based, cross-sectoral, purpose-built communities, right? It's the community quarterback idea. So these are some of the other things I wanted to really tell you guys a little bit about. Things that have happened mostly in the last year that are really moving forward this conversation. So how many of you have heard of the RWJ's Commission to Build a Healthier America? Not that many, some, okay. If you can, definitely go. This is another great website to go to. 3 recommendations: increase investment in early childhood, increase the links between the medical system and the public health system, and increase the collaboration between community development and health. So they really saw, so community development is one of their 3 recommendations. It's very, very well written. It has a lot of, actually, I think a lot of those slides, the graphs came from that. The Opportunity Finance Network, OFN is, for those of you in that area, it's the CDFI, it's the Community Development Financial Institutions umbrella organization. Health is now a theme in their regular conference, so it's seen as part of the conversation. In addition to some of their other publications, the Fed continues to put out work. One of them that Ian led, was the editor for, was the focusing on social impact bonds, among other things. So again, the community development investment site at the Federal Reserve Bank of San Francisco is really a useful tool. And I'll say the Chicago Fed has also been publishing work relating community development and health. Pediatrics, of all things, a medical journal. I must say it's an extremely well-written article. So there's an article coming out late this year, early next year, that I wrote with David Erickson, and it is bringing the idea of social exclusion, which is wrapped around the idea of bullying, to the community level, and saying that what we see with concentrated poverty is a form of social exclusion. It's kind of bullying on the community level, and that community development is the solution to the community bullying. And as far as I know, this will be the first time that the Community Development and Health link has been published in a medical journal. So it's very exciting. I'm going to throw it in the face of all my medical colleagues. It'll be very fun. They don't know what I do. Where are you going? Why are you in Charlotte? Social capital markets. Who's heard of SOCAP? So some as well. So Social Capital Markets is an annual meeting in San Francisco. It brings together social investors and social entrepreneurs People trying to do good while also running profitable businesses, and those who want to invest in them. So last year, so it's in September, yeah, it just happened. So a year ago was the first time there was a health theme, and I was the leader, the content leader of the health theme. And we really focused pretty heavily on community development as a way, because community development is very heavily loans-based, and you make money if you lend people money. And so that idea of considering community development, building buildings and investing in communities as a way to actually do a social good is pretty new to this, because these folks are often very technologically focused or very internationally focused. So it's a way to start to get private investors and some of these the social impact community to think about community development as a way of having impact. SoCap Health was this summer. We held it in New York City, specifically focusing on health, and to be closer to the banks and the insurance companies, and it went well too. Health Affairs, the journal Health Affairs, it's impossible to get these articles independently if you don't have a university affiliation or maybe a Federal Reserve affiliation, but we'll try to make sure we get these out. There was a small cluster of articles in 2011 that are all very good about the community development and health link, but there's a full issue coming out in November. All the articles. Ian's got one in there, I've got two in there about metrics in this area. So it's really about the whole arena of community development and health, so that'll be exciting. Partners in Progress is the City Foundation, Low Income Investment Foundation, or Low Income Investment Fund. They had $3.25 million. They distributed across 13 communities they identified as community quarterbacks, and it's actually going very well. I just was talking to Nancy Andrews, and she said she was shocked by what's happening. Yeah. Is anybody here who's...
Five of them are here.
Five of them are here. Oh yeah, so that actually makes sense. So I think hopefully they will expand this because it's been very effective. We'd like to see the money larger, frankly, too. Success measures, neighbor work. Success measures has been around for a while, but health is now being added. In fact, I was just at a working group meeting in Boston for that, to figure out what does that even mean to include health in the success measures. And then finally, the How Housing Matters is, that's the MacArthur Foundation, paid for a series of studies to connect housing to a variety of social outcomes. And I was specifically at the meeting for healthy child development. So again, really trying to make those links more concrete, which makes it, I think, easier for all of you to make the argument when you're talking to investors and colleagues and boards and school boards and mayors and whatnot. Couple last things. Last year, a couple funds have been created. The Healthy Futures Fund is LISC, Morgan Stanley, and the Kresge Foundation. It's investing. It's $100 million to provide low interest capital to community clinics that go outside the clinic walls. Recognize the community as the focus of their health efforts. The Healthy Neighborhoods Equity Fund is really interesting. It's an equity fund. So these are people who are investing their real money based on transit-oriented development and the increased property values and increased business opportunities in these areas that also have protected affordable housing. First time that we know of that there's been an actual equity fund. So if this goes well, it bodes well for our future work in that area and kind of opens up a whole new arena of investment. Social impact bonds. Gosh, last year there were a handful, and now they're sort of sprouting up all over the country. So it's monetizing specific health outcomes that are very expensive for the system. And as many of you probably know, it's basically a bridge loan by investors to the social service agency to try to reduce these expensive things like diabetes, asthma admissions, special ed. And the government then, if you reach certain thresholds, will pay back the investors with interest and keep some of the money. And what I love about it is when it works, everybody wins. The kids win, the adults win, the investor wins, the social service agency that wants to do it wins, and the government wins because they're spending less money. So it's kind of one of these rare circumstances. Now, they're not appropriate everywhere, but they're an amazing opportunity. So I will finish. We have a video. So this is for my new Build Healthy Places network. And it, as Kathleen mentioned, it's really to provide the support and sort of hopefully support the energy. What we've been doing is these meetings have all this great energy, but no one knows what to do afterwards. How do you make these connections? And we want to, this meeting feels like it's a Build Healthy Places network meeting. So I want all of you to join up or participate, and I'm going to put a lot of information online about the work that's going on here. But this video is actually not quite finished yet. And it will, so this is the world premiere right here. It's going to be finished like next week. So you're seeing it here, and then I'll turn it over to Ian.
Nearly 1/5 of all Americans live in low-income neighborhoods, where achieving the American dream is often beyond reach, where there are not enough opportunities for a good education, a good job, and good health. For decades, the community development and health sectors have worked to improve the lives in these places, working side by side, perhaps even with the same people, but often not working together. Today, collaboration across these sectors is growing. There are more places where community development and health are working hand in hand to improve both neighborhoods and the lives of the people who live in them, working to reduce poverty and improve health together. Innovators are leading the way, recognizing the importance of places where people live, learn, work, and play. For example, in New Orleans, the Refresh Project offers healthy, affordable food and health education, but also training and jobs as an anchor for workforce and economic development, improving health and improving lives. In the Gulf Coast of Texas, Neighborhood Centers, Inc. is dedicated to improving communities and the lives of people in them, focusing on 6 essential components: education, housing, connection, health, economic opportunity, and infrastructure. When a neighborhood reaches its full potential across all of these, the community thrives. In the East Lake neighborhood of Atlanta, purpose-built communities has transformed a once struggling neighborhood into a vibrant, sustainable community by incorporating wellness resources with mixed-income housing and a cradle-to-college education pipeline. Employment has increased from 13% to 70%. Violent crimes fell by 90%, and high school graduation rates are up from 30% to 78%. All of this progress is linked to better health. There are so many bright spots, efforts that are improving health and improving lives, helping people and places, from the urban apartments of the Mariposa Project in Denver, to the Fruitville neighborhood of Oakland, California, and the communities for healthy food in New York City. Examples from around the country show that we can, working across sectors, create better solutions and greater impact. The need to work together is strong, interest continues to grow, and outcomes are promising. But we also know that connections are key. The Build Healthy Places Network is the connector. It's the place to find out what others are doing and to talk about what's new. It's a place to ask questions and to share answers and to get excited about progress and successes across the country. So connect with us on the network and become part of a shared vision, communities where all people can live rewarding and healthy lives.
You saw it here first.
Thanks, Doug. Wasn't that great?
Yes.
Yeah. So I'm not as brave as Doug, so I'm going to bring my notes with me in case I lose track. I get to talk about the fun stuff, scope of the problem. So we heard from Doug, there's all sorts of great examples of successful collaborations between the community development industry and the health sector, and all sorts of kind of green shoots that are coming up that are transforming neighborhoods across the country. The problem is that the scope of the problem that we're dealing with is absolutely enormous. There are over 3,500 basically neighborhoods of concentrated poverty in the United States. The poverty level for a family of 4 today is about $24,000 a year. 20 million Americans live on half of that, which is to say about $1,000 a month, family of 4. 1,700 high schools are graduating less than 60% of their students. And 80% of counties in the United States have poorer health outcomes than most of the industrialized world. So this is the scope of the problem. And it doesn't match the scale of the solution, is basically the takeaway. One Refresh project, as great as it is, one Neighborhood Centers, Inc., Harlem Children's Zone, 8 or 10 now purpose-built communities, 100 purpose-built communities isn't enough to meet the need. 3,400 neighborhoods of concentrated poverty. So the question is, how are we going to take these individual efforts, these success stories, and scale them up so they can solve the massive challenge that we face? And of course, the answer to that question is systems change. So that's The Matrix, if anybody hasn't seen the movie. And this is a quote from an author and a futurist. The future is here, but it's unevenly distributed. And I would sort of rephrase that a little bit for this audience, and I'd say the future is in this room, but there's only so much that you can do without systems to support your work. Because we have the building blocks, right? We know what works. We wrote a book about what works. We have the ideas. We know who the partners are. We have the money. Doug mentioned the $2.9 trillion that we spend on healthcare, right? The money's there. We don't have the capacity yet, and that's where systems change really comes in. We have the creative thinkers, and we have the shared value system. And I think what we need to get to when we talk about systems change is a place where anyone can create a purpose-built community or a community quarterback or an institution that is capable of ending multi-generational poverty. So in this effort, I think it's important that we think about the tent that we're in. And I would challenge everybody to look at this list, and this is just sort of, Doug and I putting our heads together and coming up with a list, and I'm sure it's missing a few key players. But look at this list and think about, who are you not working with? Are you working with your local nonprofit hospital? Are you engaging them on their community benefit requirement, which is an IRS-enforced requirement that they provide indigent care to low-income people, which after ACA will go down, right? Because most people have health insurance. So what are those nonprofit hospitals going to do now that they can't just provide indigent care? Well, maybe they should invest in affordable housing or place-based community development or early learning. So engage with your local nonprofit hospitals, obviously foundations, but also insurance companies, pension funds, religious organizations. I think we're all sort of in the same boat, and we need to stop thinking of each other as kind of operating in our own silos, because everything is health. All of our work is health, and we need to be working together. So those are just some of the partners, but there are obviously many more. So this is interesting. So to get to scale, this is kind of, I know it's a simplification, but this is where we need to get to if we want to get to scale. And we're way down here. So this is Tom Cousins, right there. And then the small chasm was going from Tom Cousins to purpose-built communities, right? Taking that one idea and creating a network that can support similar ideas across the country. So we're pretty much in here right now. And we know what works. We know the folks in the room are innovators and are pushing the envelope. But to meet the need, we got to jump this big, scary chasm and get here so that the majority of our interventions have the qualities that Doug was talking about earlier. So that's the challenge, but also the opportunity. So what systems changes are we talking about? And I think there are three main buckets that I want to touch on quickly. The first is data, the second is policy, and the third is finance. So really quickly, data. So I think we all know on some level, and it's scary and expensive and frustrating, but we all know that we need to do a better job of measuring our progress. We need to have a baseline measure. We need to know, are we actually improving the lives of the people that we care about and that we work with? We need to know for our own purposes, but policymakers and funders and investors need to know for their purposes too. So we need to develop a more robust data collection and analysis system that we can all use that's reliable and robust. So we need to do that. We also need, I think, to develop the capacity to pick a spot on the horizon that we can all sail towards. Right now, we're all kind of on our own courses, and that's fine, but if we can all pick the same spot, potentially our collective impact will be much larger than pursuing this sort of individualistic, siloed off approach. And data helps us do that because we can all kind of keep track of how we're doing and are we actually getting to the place on the horizon that we all collectively agreed to. And then finally, and I think, yesterday Jack Shonkoff was talking about the LIF social impact calculator. It's a wonderful innovation. We all need to think about our work in those terms. And the calculator, for those of you who haven't had a chance to play around with it, sort of looks at impact, I think, in 5 dimensions: housing, education, transportation, early education, and health, and then assigns an economic value to those things and says, okay, this is the social impact that you created based on the investment that you made in the low-income community that you work in. We need to develop many, many, many more of those tools because they really crystallize the importance of the work and put it in terms that funders and policymakers and people that have to message this, particularly with respect to health, because it isn't as common sense as most people, I think, wish it was. We need to be able to translate our work into dollars and cents in a lot of cases to make that case. So data is a big bucket of system reform that we need, I think, to take this to scale. Policy. So breaking down silos and rowing in the same direction. Two, I think, mixed metaphors there. So two cliches, but I think if you strip away the cliche and think about what this really means, and this is just, I can hear it coming out of my mouth, incredibly boring. Public sector procurement reform. That's what we're talking about. And I think if you really distill that down to what it means and why it's important, it's moving the government away from a procurement approach that buys programs with the hope and expectation that programs will produce the outcomes that the government finds valuable, which makes some sense. But in, I think, practice, we have come to understand that just because a program seems interesting, or the more cynical side of me has an affiliation with the elected officials in office, whatever it is, just because those programs seem like they're going to produce the outcomes that we care about doesn't mean that they actually will. So we need the government to actually buy what it cares about, which is better outcomes. If they want a reduction in childhood obesity, they should pay for a reduction in childhood obesity. If they want kids to do better in school, they should pay for kids to do better in school, not for the programs that hopefully will produce those outcomes. So that's, to me, the big the big hurdle. This is going to be the hardest, I think, of the three to accomplish because of all the reasons that we're all familiar with. But it presents a really interesting opportunity, particularly for this health and community development relationship. And I would point to sort of the coordinated care model as a great example of that. So for those of you who are not familiar with coordinated care, it's kind of a creature of the ACA, of Obamacare. It's this concept that if you get a network of providers together, give them a global budget, so here's a fixed amount of money, you are responsible for the care of the people that are in your network, and you need to keep costs down. So if you overrun, it's on you. You got to come up with the money to pay for the shortfall. So accountable care organizations are the models that came out of ACA. It's explicitly targeted at Medicare patients, but there are other examples of this. Oregon and Ohio, I think, both got Medicaid waivers to create essentially coordinated care organizations to serve the Medicaid populations in those states. And what it does is it creates this really interesting opportunity where it aligns the incentives of those coordinated care organizations in such a way that they can look at a range of potential investments. They can wait until somebody gets sick that's in their network, and then they can treat that person and pay for that. Or they can invest in early childhood education, or they can invest in a purpose-built community. And in the long run, because those investments will produce better health outcomes for the people that are affected, those healthcare costs come down, and the coordinated care organization ultimately benefits financially. But that innovation, as simple as it is a huge policy reform. It's taking government funding, handing it over to a public-private organization, giving them sort of big goals on a cost and care sort of dimensions, and saying, okay, figure it out. Spend the money the way that you think is most appropriate, and we'll save you money. But make sure that you meet the health needs of the people in your community. So it really is a radical departure from what we do now, but a huge opportunity to bring community development and health together in a meaningful way. But policy, procurement reform, it's fun stuff. And then finally, the third one is finance, and it's not just finance. It's really creating a market that values health, not just healthcare. We have a great market for healthcare. We have a $2.9 trillion market for healthcare because that's what we value. We value healthcare, but we shouldn't value healthcare. What we should value is health, but we have no market for that. And I know that I'm at the Federal Reserve, and I'm probably more comfortable than the average person with kind of using markets to solve problems. And I acknowledge all of the problems associated with using markets to solve social problems. But in my mind, if you want to fix 3,500 neighborhoods of concentrated poverty, you need a system that's big enough to do it. And I can't think of a system that's right-sized better than the market. We just have to get the incentives right, which, of course, is where the devil's in the details. But if we get to that point, then we can all sort of reimagine the work that we do as producers of better health instead of producers of kids that can do well in school or people who are job ready. As important as that stuff is, we can kind of change the script a little bit, and we can become producers of health the same way Johnson & Johnson is producer of health care products, or Genentech is a producer of innovative drugs. There's for the health fairs article that I'm submitting next month, I spend a little bit of time talking about hepatitis C transmission. So hepatitis C is very bad for you. It's deadly. It's also very expensive to treat. So to treat one person that has hepatitis C, it costs about $84,000 per treatment. But it's mostly a behavioral issue. It's people that are doing unsafe things, sharing needles and having unprotected sex, stuff like that. And if there was a program that could come in and educate them about how they can behave more responsibly, it could potentially be a lot less expensive than the $84,000 treatment that would be required to treat them should they contract hepatitis C. But we have no market that allows us to make those trade-offs. We just wait until they're sick and then we treat them. But if there is a market out there that says you have an option, you can either invest in the community program that keeps people healthy and it costs a lot less, or you can wait for a few years, wait for them to get sick, pay a whole lot more, and ultimately everybody's worse off. So to me, this is the third big bucket of change that we need, is to kind of move us in this direction where we're thinking of ourselves as health producers and making value propositions to health buyers, so insurance companies, hospital systems, government, anybody that values better health, mostly because it affects their bottom line, right? Because it reduces healthcare costs. Once we have that in place, it really opens up just an amazing financial toolbox that includes social impact bonds. It includes a whole range of pay-for-success arrangements where you're basically paying to keep people healthy and then paying back the investors that bear that risk with the healthcare cost savings that accrue over time. So the combination of reimagining ourselves as health producers and all of these sort of related financial products to support that marketplace is, in my mind, the third kind of big system change opportunity that we have in front of us. So I'm not going to conclude with that. I want to conclude just really quickly. And I didn't want to spend too much time on Pay for Success because I did that sort of a session on that last year. Anybody that wants to talk about Pay for Success, please ask in the Q&A, and I'm happy to spend more time on that. But I didn't want to conclude on that. I wanted to conclude on sort of a more provocative note, sort of a hopeful note, and just make the observation that I was up in Oregon last weekend visiting my in-laws, and we were driving to the beach, and we lost radio reception except for NPR, right? So I'd like to say I'm more sophisticated and I listen to NPR when I don't have to, but in that case I had to listen to it. So, and I was listening to it, and an author interview came on. So there's an author, Stephen Johnson, who just wrote a book, How We Got to Now. I'm not sure if anybody's read it. I haven't read it. It could be terrible. The interview was interesting, and that's what I want to talk about. And he mentioned in that interview this concept of the Gutenberg Effect. So everybody knows the Gutenberg printing press, the Gutenberg Bible. So the printing press was invented in the late 1400s. And of course, it was a huge invention for Europe at the time. And all of a sudden, these reading materials were being distributed throughout the entire continent. And so people started reading more. And at that moment, everybody realized, or a lot of people realized, for the first time in their lives, that they were farsighted. They couldn't read anything. And so overnight, a whole industry was created to make glasses, right? So across Europe, all of these sophisticated skilled glass workers came online to meet the demand for reading glasses, so people could read these new publications, which is interesting enough. I think that story could end there. That would be interesting. But what's fascinating to me, and this is his point about the Gutenberg Effect, is that at the same time, because all of a sudden you had all of these sophisticated, skilled workers manipulating glass, they started manipulating glass for other purposes, which led directly to the invention of the microscope, which led directly to the discovery of microorganisms, which is the foundation for modern medicine. So the printing press is responsible for your job, which is amazing. And it's fascinating, and I hadn't really thought about it that way. And so since last weekend, I was thinking, what I was thinking about this presentation and preparing for it, and I was thinking, what is our Gutenberg effect going to be if we actually succeed in bringing the health world together with the community development world? Let's sort of imagine the possibilities. I mean, they're legion and exciting. And I mean, you could just to throw a couple out there, just to kind of get your juices flowing to some extent. I can imagine Eastlake Foundation, for example, evolving into a self-insured HMO, as bizarre as that sounds. And you'd have Eastlake betting on their ability to keep the residents of Eastlake healthier than Kaiser Permanente, and say we can do that better because we're affecting the social determinants and not waiting for people to get sick. So I can imagine something like that kind of effect coming out of bringing these two fields together. I can imagine, this is super crazy, I can imagine a neighborhood incorporating itself and selling stock in itself on the basis of projected cost savings to the healthcare system. Buy my stock, I will keep the neighborhood healthy, and you get to share in the upside. I can imagine pay-for-success contracts that are tied to decreases in cortisol levels, which are the stress hormone in the body. So you keep stress hormones down, you get a success payment. Or maybe tied to executive function in 5-year-olds. I think it's really the sky's the limit. I think we're only limited by our imagination. And I think that the potential effects, and Kathleen mentioned that I was a philosophy major, and that's super boring. But there's a philosophy of science that says that we can't see the next paradigm until we're in it, right? We can guess, but until the paradigm has actually shifted, you don't realize that you're in the new paradigm. And I think we're right at the precipice, right? We're not in that new paradigm yet, but it is shifting, and I think we should just allow ourselves to be as imaginative as possible in terms of the partners that we're working with, in terms of the funding streams that we tap into, in terms of the interventions that are going to have this positive health effect, and really just take advantage of this incredible moment. Because who knows, just like the printing press created modern medicine, who knows what can come from the great work that all of you are doing and bringing these two fields together. Again, I think there are some big systems changes that need to happen, but the opportunity is huge. Obviously, I'm excited about it. I hope all of you are too. And here are just some last resources. Thank you very much.